You see less metabolic dysfunction in people that are 20. They just haven't gotten it yet. So they're more fertile, even though they're probably on that path with the environment we live in. It's not affecting them yet. So because you see more metabolic dysfunction as people age.
More than 73% of Americans have overweight or obesity, while more than 12% have food insecurity. America is getting heavier, sicker, and more isolated from each other every day. Our motto, Move, Eat, Give, reflects our belief that virtually every problem in America could be fixed if we took better care of ourselves and took better care of each other. Welcome to Interrupt Hunger's Move, Eat, Give podcast, where we talk with experts in exercise as medicine, food as medicine, and food insecurity. And understanding that knowledge isn't always enough to help you lose weight. Every other episode showcases someone who's lost at least 10% body weight to share exactly how they did it. Interrupt Hunger is a 501c3 nonprofit which helps you lose weight while feeding the hungry. Bring our free 12-week weight loss challenge and donate your weight program to the places you live, work, and pray. We fund our mission with sales from our Move, Eat, Give bracelets and clothing, so please visit us at interrupthunger.org to show your support. 50 meals are donated for every item sold to the nation's largest hunger relief network. So you get to look good while feeling good. Now on to today's episode. Courtney Younglove is a physician, dual board certified in obesity medicine, obstetrics, and gynecology. She is one of only about 100 clinicians in the U.S. that has earned her OMA fellowship in the field of obesity medicine, one of the highest honors bestowed upon clinicians who demonstrate dedication and commitment to the clinical treatment of obesity and obesity-related diseases, and was recently elected to the Board of Trustees for the Obesity Medicine Association. Dr. Younglove is the founder and medical director of Heartland Weight Loss, an obesity medicine practice with clinics in Overland Park, Kansas, and Lawrence, Kansas, the chief medical officer at Journeys Metabolic, a digital therapeutic solution for value-based organizations impacted by our current metabolic health crisis, and she is currently building WellMe, a company providing tools to self-funded employers struggling with obesity in their workforce. Dr. Younglove, thanks so much for joining us today.
Thanks for having me.
There's just not a lot of people who are experts in both obstetrics, gynecology, and obesity medicine. So it's a treat to get to learn from your experiences today. So I've been married for 30 years. I have 3 daughters, and I have heard about PCOS from time to time, but I never really understood it too much until after seeing that post on LinkedIn with you and really diving in it and talking to my wife and girls about it. I had no idea the interplay between PCOS and infertility and obesity. So we before we go down that road, why don't you just tell us a little bit about you and your practice?
That good stuff.
Yeah, sure.
So I practiced OBGYN for 15 years. It was a long time. I was a women's studies major in college, went into OBGYN right out of med school, and loved that field. I absolutely loved it. And dealt with a lot of patients with PCOS. I mean, I entered the field in the early 2000s as this obesity epidemic was really skyrocketing, and it really became a big focus of my practice. As we'll dive into PCOS, there's a huge overlap with metabolic disease and obesity, which seemed to be the thing that was also what my patients asked me about all the time. So in early 2010s-ish, I went to a conference on obesity medicine, trying to figure out, can I figure out this piece of it that seems to be lacking in my education, and really got hooked to the field of obesity medicine and dove into that field, and the rest is history. I mean, I got bored in obesity medicine in 2014, at which point I became the OBGYN in Kansas City that saw patients with obesity. I mean, it just kind of naturally went that way of, I was very inclusive to patients with obesity, which wasn't normal at the time.
And that's quite a few years ago, sure.
That was a long time ago, yeah. And it, for a long time, obesity was really looked at as this thing of sloth and gluttony, and people didn't want to treat patients with obesity. They were labeled as non-compliant or lazy, and it just never felt that way to me. And so my practice very quickly shifted to a practice that would heavily focused on patients with obesity, which meant a lot of PCOS, which meant a lot of infertility, which meant a lot of complicated pregnancies, because women with obesity tend to have a much higher rate of pregnancies complicated by gestational diabetes and gestational hypertension and preeclampsia and C-sections. And so it just evolved that way without me really meaning for it to do so. And eventually I said, I need to treat this obesity. Like, I don't have the space in a OBGYN clinic to really treat obesity the way it needs to be treated. I grappled with a lot of ethics in my own world of what do I do and how do I do this right. And I finally just said, I'm going to go practice obesity medicine, hang a shingle, do this thing that really nobody else is doing in town, and let the obstetricians do the obstetrics and the gynecologists do the gynecology. And I'm just going to do the obesity piece, which has been wonderful, but it meant I had to leave that OBGYN piece behind. So I've just been solely obesity medicine now the past 5 years-ish or so, I think. For a while I was doing both, which is really hard to do as a physician and as a mom. And so I've kind of siloed that direction now, but it's still my love. I mean, I still was a women's studies major. I still am a gynecologist. And so there's probably a place for that to really take off someday. But, with the obesity world we've been in the last year, now obesity medicine's booming and we're trying to figure out how to do that realm. So I wear a lot of hats, but women's health is a passion of mine and obesity medicine is a passion of mine. And yes, that's where PCOS and pregnancy complications really come in. So,
well, it's fantastic whenever you have multiple passions in your life, and you're lucky enough to get to do both of them. So that's pretty cool.
What I just need is more time.
Yeah, don't we all?
But that's okay.
I know.
They'll
that's
come.
crazy.
I have lots of years to live still.
So the it's really neat. So the noise level for folks with obesity and overweight, it's really growing. I think it's taken a while. It's very slow, but the bias and the stigma that comes along with that is finally starting to crack. And it feels so refreshing. And this is kind of my world now. But when I am confronted by it still, I'm just kind of thrown off, like, oh my gosh, we still have so much work to do. But the other part of this is, there's so much overlap, obviously, as you know, with folks with obesity and other comorbidities, where, whether it be mental health issues or cancer or just a whole host of diseases. So I think physicians are just gradually going to be forced to become, like, have some type of component of obesity medicine. And then the flip side of that is, like, I think most physicians are going to have to, kind of become lifestyle medicine physicians as well. So that's good news. We're going in the right direction.
Yes, I think we're going in the right direction. I think it's going to be a messy trip to get there, but I think we will get there. It's just going to be the mess before we get there. But that's okay.
Yeah,
most physicians, truly at the heart of what we do, we really do want to help people. And I think if you look at physician burnout, which I hate that term, but the reason physicians are leaving medicine in droves is because we don't feel like the current healthcare system is really helping patients very much. We're just becoming prescribers. And I think if we had the capacity and the space and the system was set up to let us do a lot of lifestyle medicine, we would. I think the heart of our hearts, we do want to help people. So we just have to get there.
Yeah. All right. Very good. All right. So let's dive into this. What is PCOS?
Sure. So PCOS stands for polycystic ovarian syndrome. So it's a syndrome, which just means it's a constellation of things that occur under an umbrella versus a diagnostic disease, like you have to have this lab test kind of thing. It is the most common endocrine disorder of reproductive age women, which says a lot. We hear about thyroid diseases all the time in women, but PCOS is the most common disease or disorder of reproductive age women. And it depends on which criteria you use before you can say the prevalence. So just saying it affects a lot of women is probably worthwhile right now, because there's a couple different buckets of how you define it. The most common is called the Rotterdam criteria. That was thrown out there in about 2003. A bunch of experts came together and said, how do we define this thing? How do we say, yes, you have it, or no, you do not? And so the Rotterdam criteria means you have to have 2 of 3 things. One of them is, in medicine, what we call oligo ovulation or anovulation, which means ovulation is the making an egg. When we have a fertile cycle, we make an egg, and that egg either creates a fetus or it doesn't. And anovulation means that doesn't happen. And oligo means it happens less than it should. So that's the fancy Latin overlap of medicine. So the average menstrual cycle in women lasts about 28 days. So normal is 21 to 35. There's obviously a range, but it's about every month you have a menstrual cycle. And so to have less than normal, it means you need to have cycles more than 35 days apart or less than 8 cycles a year. So women with PCOS tend to not ovulate very much. They don't have that cycle where they release the egg. So that's one criteria. A second criteria is excess androgens, or excess, what we call male hormones, although women have testosterone. We all do through all of our life. It's actually our most dominant hormone. But having excess testosterone relative to our other sex hormones. And that can either be diagnosed on a lab test, and you can say, yes, the testosterone is high, or it can be diagnosed clinically, and you can have features of excess androgens, which for women typically is abnormal hair growth. So hirsutism, which is having kind of a male pattern of hair growth. So hair on the chin, on the cheeks, on the chest, in places that women are not traditionally thought of having hair growth. So that's hirsutism. It can also show up as acne or female pattern hair loss. Those are not actually technically criteria of PCOS, but we see them in that realm. So one is the ovulation, having less of it than you should. 2 is having excess androgens. And then 3, the third criteria of PCOS, remember you have to have 2 of 3, is having this visual appearance of the ovaries of having lots of tiny little cysts within the ovaries. That's why the term came up of polycystic ovaries, is you have all these tiny little follicles, these things that are supposed to become eggs that are bigger than they should. And so obviously most people can't see their ovaries. They're buried way inside of us. So we as gynecologists can see the ovaries by doing an ultrasound or by looking at the ovaries if we're inside the pelvis for some other reason. So if you put a laparoscope inside of somebody to tie their tubes and you look at their ovaries and you go, oh, wow, there's lots of little cysts all over them. Most common is obviously ultrasound because it doesn't involve anesthesia and that kind of thing. But so that's the third criteria, is having these tiny little cysts all over the ovaries that usually makes them bigger. I mean, you know, if you have tiny little cysts all over your ring finger, that finger is going to get bigger than your other fingers. So it's not just having one cyst on the ovary or an ovulation cyst on the ovary. It's having these tiny little cysts all over the ovaries that we see when we're looking for that. So with PCOS, you have to have 2 of those 3 things. And because one of them doesn't necessarily mean you have PCOS. So a lot of women, especially when they first start menstruating, have polycystic ovaries, but they don't have the other things. So that doesn't mean they have polycystic ovarian syndrome. They just have lots of cysts on their ovaries. Okay, that's fine. That in and of itself is not anything. It's just a thing. And some women have excess androgens, especially as they're going through puberty. That doesn't mean they have PCOS. It just means they have the extra androgens at the time. So PCOS is having 2 of the 3 criteria.
Okay, I got it.
That's the diagnosis. Medicine's complicated that way, but there's lots of reasons to have all kinds of other things. There's, other reasons to not ovulate. So that's that. And then what's the intersection with obesity? You want me to go there? Or?
Yeah, sure. That was my next question.
Yeah. So not all women with PCOS have obesity, and not all women with obesity have PCOS. So they're different things. It's just like not all people with high blood pressure have obesity, and not all people with obesity have high blood pressure. Okay. So they are different manifestations of a problem. And this takes us back to how do we define obesity, which is really kind of where I kind of backtracked in my career of, I don't understand this. We used to call it atypical PCOS if they presented with PCOS and not obesity. And I was like, well, God, like a third of those people have atypical PCOS, which means it's kind of common. And so if you really look at the etiology of obesity or the etiology of PCOS, the etiology of these things that we call comorbidities of obesity, they're not all the same, right? They're all different, but they all arise from the same common mechanistic problem, which as medicine's evolved, we're starting to see that. And we knew it, but we haven't put the pieces together in medicine. But so all of these things, obesity, PCOS, hypertension, high cholesterol, these kinds of things are all a result of metabolic dysfunction. So somewhere within the body, the metabolism the metabolic switch, these things is breaking. And the manifestation for many people is obesity, but not all of them. And the manifestation for women of reproductive age is PCOS, sometimes with obesity, sometimes without. Sometimes the manifestation is high cholesterol, sometimes it's fatty liver, sometimes it's ovarian cancer, sometimes it's, that's common etiology is this metabolic dysfunction. And in women of reproductive age, a lot of times we see obesity and PCOS as that manifestation. So at the core of it, PCOS is being caused by this metabolic abnormality, which is usually caused by insulin resistance, which is typically caused by food. Not always. Sometimes we have insulin resistance because of chronic high levels of stress that raise our insulin. Sometimes, and this is where it's really getting gray, is we have high testosterone levels as the primary problem with this PCOS, which then causes insulin resistance. So it is complicated. I mean, medicine's just not super straightforward, like a lot of people would like to believe, but this metabolic abnormality is driving PCOS, which then often puts people into a spiral. And so insulin resistance raises testosterone. And guess what? Testosterone in women worsens insulin resistance, which then increases testosterone, which then increases
the massive
insulin.
cycle.
So the chicken or the egg cycle.
Yeah, sure.
Yeah. And so if we get there, and then it's really hard to pull ourselves out of it because it's complicated.
And so is it safe to say that PCOS is the leading cause of infertility in women?
I would imagine today it probably is. And that's probably recent. I mean, 25, 30 years ago, I would say the leading cause of infertility was probably, and this is where I'm not a reproductive endocrinologist or specialist in infertility problems, but I mean, there's a lot of reasons for infertility. Sometimes the tubes are blocked. There's other reasons, but I would say today it's probably has to do with PCOS. Yes.
Wow.
Yes.
Oh,
and also advanced maternal age, which is also going along with that, is the older women get, the more likely they are to develop metabolic disease. So we've kind of pushed those two things down the road together. So there's probably that combination too. You see less metabolic dysfunction in people that are 20. They just haven't gotten it yet. So they're more fertile, even though they're probably on that path with the environment we live in. It's not affecting them yet. So you see more PCOS as people age because you see more metabolic dysfunction as people age.
Yeah. So we're seeing more. So we're seeing more PCOS and what? So like you said, just because you have PCOS or just because you have obesity doesn't mean you're necessarily going to have infertility problems. There's a host of other disorders, conditions that come along with that. Well, what percentage of infertility problems? I mean, it's not that common.
It's more common than most people think. It's such a complicated stat because do you know you have it if you're not trying to get pregnant? Right?
Yeah, good point. Yep.
I mean, and there's a lot of people, and this is where it just gets so gray. I mean, I run into people all the time that say, I can't get pregnant, so I don't take birth control. But that's kind of a loaded statement, right? Are you trying? Or are you not trying? Are you having sex during that point of the month when you should be fertile? And so I don't know. It's very gray. It depends on how you define it. Of the people that step back and say, right now, I'm going to start trying to get pregnant on purpose, how many of those people are successful? That's probably a much more accurate statistic than I could probably find if I really nailed it down. And at what age are we talking about?
Yeah, sure. Yeah, there's a lot of what ifs, a lot of variables. That's okay. That's okay. And, yeah, I know. It's I mean, 9 out of the 10 top causes of death right now are nutrition related, and we're just finding more and more that so much comes back to this and sedentary lifestyle, and so we just got to work to get healthy. Okay, so so you're trying to get pregnant. You find out you have PCOS. Then what?
And
what do you do about it?
This probably goes back to a lot of people don't know they have PCOS because they start birth control to prevent pregnancy. And so one of the treatments for PCOS is oral contraceptive pills. So a lot of people don't even know they have it because they can't diagnose the ovulation piece because you're on a thing suppressing ovulation, and then
Oh,
you're inadvertently on a treatment for it. So like, let's say a scenario is somebody comes in who has been on birth control pills for 5 or 6 years, or had an IUD or something to, so that they haven't really thought about their ovulation issues. So they decide, okay, I want to start deliberately ovulating and letting my body do this thing, and I want to get pregnant. So then they have to see what happens. And so they stop birth control and they start seeing what their natural cycle is. And it'll take a few months to reestablish that natural rhythm that we have as women. And guess what? We're not perfect. So bodies get thrown off all the time by illness or stress. And so it's normal to have an anovulatory cycle here and there. But let's say you do that for 6 or 9 months and you come back in and you say, hey, doc, I don't know, my cycles aren't regular anymore. And we say, okay, well, now you're off your pills. Now we're establishing your normal rhythm. Guess what? It's not a normal rhythm. It's an abnormal rhythm of cycles. Maybe we should look into this idea of PCOS. And so then you have to do that workup and you say, do you have high androgen levels clinically or by labs? And should we look at your ovaries to see if you have polycystic looking ovaries? And then you do this workup and let's say you get diagnosed, which is going to be some, but not all, So let's say you have this diagnosis of PCOS and you say, okay, now I want to get pregnant and I have this diagnosis. Then we have to go down that path of what do we do for you? And there are things that we do in medicine, and then there's things we do in lifestyle, and hopefully those are one and the same, but most of the time they're not. As somebody with a background in lifestyle medicine, in metabolic health, the first thing I would say, and the first thing I said to my patients is, okay, let's get the insulin down. Because then that solves most of the problems. And that's usually by lifestyle. So that's get the insulin down. That's what I do for a living in my clinic, is get the insulin down. That's dietary modifications. It's better sleep. It's managing stress, because that raises cortisol, which then raises insulin. So it's all this lifestyle stuff.
so let me ask you real quick. So just to be clear. So insulin goes up, testosterone goes up, and if you already have PCOS, does that just make it? That makes it worse.
Yeah.
So
it's like
you want
lemon juice on an open wound. Yes.
Yeah, that makes sense. So getting the insulin down, gets the testosterone down, gets the resulting problems from PCOS improves.
It helps. Yeah.
Okay.
Now, sometimes it's not enough, but yes, when you fix the insulin, you fix what's called sex hormone binding globulin, which carries around the testosterone. And so, yeah, and you have to kind of fix that problem. So the easiest lever to turn to bring that testosterone down is to lower the insulin.
Got it.
And the easiest way to lower insulin is to not stimulate it in the first place. And that goes back to that obesity medicine piece of, certain things that we eat raise insulin. And if we have something called insulin resistance, then that insulin stays up for a lot longer than it should. So just not bringing it up in the first place is ideal, which it's hard to heal the insulin resistance piece if you're constantly being bombarded by insulin. So that's that dietary beginning.
How before we get into, what your approach is to the lifestyle and trying to get that insulin down, like how long of a process, how much do you need to get that insulin down? How much weight do you need to lose to affect change here and make things start working
variable. Again? I mean, it depends on how advanced the disease is. And we in medicine do a terrible job of quantifying that. In medicine, we just say you're fine, or you have prediabetes, or you have diabetes. And diabetes would be end stage insulin disease, insulin resistance. It's when the body can no longer, no matter what it does, get the glucose down. Before that, you have prediabetes, meaning it's struggling, meaning it's still able to crank out enough insulin to keep the blood sugar in what we deem the normal range. But for about 10 years before prediabetes is when we have high insulin levels. And so it depends on where you are in that continuum. I mean, for some people, you just stop stimulating insulin and wow, the body heals. And for some people, especially those ones they have prediabetes or diabetes, they have much further advanced disease. You probably have to do it a lot longer before the body really fixes things.
Yeah, that makes sense.
It's so hard. Yeah, it's like looking at a lawn, right? Like if the lawn's been sick for 10 years, you can throw grass seed on there, but it's going to take a whole lot more than grass seed and water,
I like it. Yeah.
And then if you keep throwing Roundup on it periodically, because that's what happens, you're really not going to get anywhere. You're going to be stuck in that cycle. And so I kind of look at insulin's kind of like that roundup, like, and now if it's coming down here and there in the rain, okay, but if it's big bursts of it here and there, and then if you turn off the watering for a while because you don't want to put the water on there, then have you backslid? And so it's such a process.
Yeah, and it's such, I mean, there's such generalizations here, but like
Yeah.
we hear it really doesn't matter what the disease is, but you hear if you lose like 5 to 10% body weight, you start to have some fairly significant improvements in health. So I'm assuming that's kind of the range that we're hopeful for. So it doesn't take a whole lot to get improvements.
And especially in really young people.
That's the good news.
Yeah, you lower that insulin, you don't even have to lower the body weight. I mean, the body weight might not even be the problem. And especially in women that don't have a ton of excess weight, you might not have to lower the weight at all. You probably just need to get the metabolic health fixed. So
gotcha. Now this is fascinating. Okay.
Yeah. It's just the way you frame it, right? Like if you have a significant amount of excess weight, but you can fix the metabolic problem that caused the excess weight, yes, that adipose tissue is still there in those fat cells, but the problem that put it there is solved. You might be ovulatory, which is kind of cool.
Yeah. Yeah, this is neat. Okay. So, all right. So, like, walk us through how you might put in your obesity medicine specialist hat on now.
Yeah.
So, like, walk us through a journey. How are you going to support these women on their journey and try to help them in their goal, getting pregnant?
If the goal is to get pregnant, then you kind of have to put a timeline on there. So if it's as soon as possible, then I'm going to lower their insulin and hope their testosterone comes behind with it, because I don't want to. We'll go down the other path, but metformin, which is a really old drug that's been around for a long time, can help lower that insulin. So I would put them on metformin. Metformin we use in pregnancy to treat gestational diabetes. So it's a very safe drug to help lower insulin if we want to move that along as fast as possible. And metformin is a great drug for helping with insulin resistance. So I use that very liberally. It's a very safe drug. It's a very cheap drug. It's got a few side effects, but guess what? The side effects really only come if you're eating the stuff that raises insulin, which you're not wanting to do anyway. So in that category, in a low insulin stimulating diet, metformin is usually very tolerable. And so to me, it would be, let's work on insulin. Let's work on dietary modifications to keep our insulin down. Let's work on good sleep to keep our cortisol down. Let's work on movement, because when you move the body, you make the muscles activate, and the muscles soak up glucose really quickly, which then means we need less insulin. So I work on movement, I work on sleep, I work on stress, because stress raises cortisol, and I work on nutrition, and then probably some metformin there. And then hopefully that's enough. Now, if you have a longer timeline of, hey, I want to get pregnant in a year, or I want to fix this PCOS and get a lot healthier before I become pregnant, putting somebody on birth control pills, if they're a candidate, will lower that testosterone. So it's an additional tool in the toolbox that obviously prevents pregnancy. There is an anti-androgen medication called spironolactone that lowers the testosterone. So that would lower the testosterone piece, but that can cause birth defects in somebody who gets pregnant. So you wouldn't want to do that with pregnancy looming. And so, it's kind of two different pathways. So those are kind of your pathways. Now, if it's not enough in a woman who says, no, I want to be pregnant right now, I don't want to take birth control, I don't want to take spironolactone, like I'm doing everything I can do to lower my insulin, I'm taking my metformin, I'm moving, I'm, doing all these things, and it's not enough, then there's medications that we give in gynecology to stimulate ovulation, to really just push past the problem. Fertility drugs, we call them Clomid, we call them Letrozole. You take them for a few days, is certain point timing in the cycle to try to prompt that ovulation piece. And we do those. That's nothing you would do as a DIY. You do that along with the gynecologist, and then usually you check to see if the progesterone level rises at the right time, to see, is it effective, or do I need a different dose? I mean, that's definitely a further path down there that you would need to work with a gynecologist, but that's what we do. You try to stimulate ovulation. And if that's not enough, then you go to a specialist who then gives you a whole slew of hormonal cocktails throughout the month to, level it up, to say, okay, we need lots of help with ovulation, and then we need the support. Since we haven't ovulated, we're going to fertilize that egg and then put it back inside of you, and then hormonally support that process. So it's just different levels.
Yeah. So it was interesting. Last time we spoke, it was neat. You said that you get referrals from the fertility clinic.
Yes.
And there's there's quite a large chunk of patients that actually don't have to go back to the fertility clinic, right?
Yes, and thankfully they're okay with that. They keep thinking my referral source is going to dry up, but they're funny. So busy. I mean, the fertility clinics that are sending to me are on like a year-long wait. So,
oh my gosh,
I'm happy as a clam if we can just take that off and say, hey, now we're pregnant, right? Problem solved, and they look like heroes for just sending them our way. So I think it works out for everybody, and then somebody doesn't have to go through IVF have that long conversation. So. Yeah, no, we love them. And those are the best patients because they want something so badly that, when you want something that's tangible and you say, okay, so yes, changing your diet's hard. I mean, it's hard for everybody. But if you say, oh my gosh, I want a baby more than I want to eat the way I've been eating for 25 years. Okay, it's just a great population in general.
Yeah, I interviewed some folks to like just share their weight loss journey on here as well, if they lost 10% body weight or more. And there's always a trigger for the folks that have, lost, we're talking like 30 pounds or more. That's a lot. So, I think the studies show that you have like a 95% failure rate if you're trying to lose 20% body weight or more. So like the human body was not built to lose weight. So
yeah, but if you also think about it, most of the recommendations for losing body weight are just restrict your intake. So you haven't fixed the metabolic disease in the first place, which it's like pulling a rubber band. You can only pull it so far, and it's miserable to restrict your intake. So of course it's not going to be a durable intervention. So this is where in obesity medicine we go back to the problem of why are you storing that fat abnormally, and why is the intake higher than it should be? And it's usually because something's driving it. So plug for a different day, but if you actually fix the root cause of the problem, which is that insulin resistance, you can do that weight stays off indefinitely as long as that insulin lowering intervention is more durable. So I think when we attack the problem wrong, the failure rate's really high.
Yeah, that makes sense. Which is what we've done for a very long time.
Eat less. I mean, I've struggled with weight since I was 12, and eating less doesn't work very long. It's miserable. I don't do well with it. But guess what? If I just eat low insulin, I can eat as much as I want. And inadvertently, I actually probably eat less than I would have, but there's no misery associated with it. So you move on.
That's a neat concept. So I think people could get their heads around that. So like, what's that mean to eat low insulin?
Well, so if you look at what stimulates insulin, I mean, besides sleep, poor sleep and stress and all of that, things that raise blood glucose quickly result in an insulin rise. So dietary fats don't raise insulin. So olive oil, coconut oil, butter, but we don't tend to eat those things by themselves. Whole food proteins like eggs and chicken and fish and those things don't raise insulin. So eat those. Eat them with the fats. They taste better if you put some butter on them or some olive oil on them. Vegetables don't really raise insulin because they're high fiber content. So non-starchy vegetables don't raise insulin. So you eat lots and lots and lots of those. Whole fruits don't raise insulin very much. They definitely more so than the other foods we just talked about. But like eat an apple, it doesn't raise insulin very much. And it's a much slower. So it's it's like a soft rise. So foods like that, beans and legumes don't raise insulin very much. So whole foods, Mother Nature foods. Those don't raise insulin much. So when you eat that stuff, you don't. Now, then you start getting into Mother Nature foods that do raise insulin more, like potatoes and rice. So some of those whole grains do. Now, again, if you're metabolically healthy, you can raise your insulin here and there, no big deal. But if you're not, then that insulin stays up for a long time. So that's where those can become harmful. But when we get into foods that really raise insulin, it's ultra-processed foods. It's the addition of flour. It's the creation of flour. It's taking a whole grain and pulverizing it into a powder that then gets absorbed rapidly through the small intestine. No matter what the powder is made out of, anything powdered just goes right into the bloodstream quickly, which then causes a rise in blood glucose quickly, which then stimulates a rise in insulin. Ironically, artificial sweeteners or non-nutritive sweeteners, because of the taste of something sweet on the tongue, they raise insulin. So Diet Coke. We probably shouldn't say products on here, but diet sodas, sweetened yogurt that tastes like strawberries or blueberries or lemons. Those sweeteners raise insulin simply by being sweet and activating the sweet receptors on the tongue. And so it's not really the calories that raise the insulin, it's the type of food that we eat.
Yeah, I get you. So just changing the diet, not restricting, like you said, and I think we all know that doesn't work. Changing the type of food you're eating, how often is that enough? Or how often does physical activity go with it? And then throwing medication on top of that.
Kind of a loaded question, because a lot of people, when their insulin's high, have a lot of inflammation, and physical activity is miserable. So asking them to do that is also really hard. But I will tell you, when people lower their insulin and that inflammation tanks, they want to move. So I think it's hard to say you need 10% of this and 20% of this and that kind of thing. We typically in our clinic start with nutrition because it's such a big lever to pull. And in my experience, most people can then pull the physical activity. They just pull it automatically. They don't even need us to say, hey, it's time to move. They go, I'm walking my dog all the time. I'm going to join a gym. I think this feels really good. I'm going to
starts to get fun.
Done. It's fun. Yes, because most human beings, like, you remember being a kid? It's fun. It's fun to move your body when your body feels good. It's miserable to move your body when the body feels bad. And so you kind of have to work upstream of the problem. So, when I was not metabolically healthy, it was miserable to go to exercise. But now I thoroughly enjoy it. It's a piece of my day that feels really good. When I live out in the country, when I take the trash cans down, it's fun to just jog up the hill back to the house because it's kind of this little burst of, I kind of feel like a kid again. But when I had excess weight and didn't feel good, that would have absolutely been a no. And I looked at people when they said I like exercising like they had two heads, right? I didn't think that was fun. So it kind of all works together.
Yeah, I think for a long time, this has been a huge obstacle that we still have ways to go, but getting folks to realize, because there's always been a huge swath of folks who love to exercise. They get the runner's high or dance or hiking or whatever their physical activity is. And then there's this other group that, like, they don't understand because they don't get it, but maybe it's because of all that inflammation and some other stuff going on. So you take care of the diet, not diet, restricted, but you change, the way you eat, reduce the insulin, reduce the stress, reduce the cortisol and inflammation, and then everything just gradually starts to get better, and you get to live to your full potential.
When you watch people become vibrant, and it's so ironic. It was where I can talk about this forever, but like, people come into the clinic thinking this 25 pounds is what's weighing me down. Once I lose the 25 pounds, I will be vibrant again. And you kind of go, well, I don't know. I mean, right? It's the loss of vibrancy is not necessarily the pounds. It's that underlying inflammation, metabolic dysfunction. Now, if getting the weight off lowers the inflammation, and that's the nidus, and that's where we begin, and that's usually where people begin, but I had a family member who got really ill, and she lost 60 pounds accidentally. I mean, she was very ill, but she didn't feel vibrant. It wasn't the 60 pounds that were the problem. It was the underlying illness, so we might package that solution up, but most people, and they put it in terms of words of weight, but they do want to feel good. And it's amazing when you don't think about your body all day long, how much better you feel about yourself, about your daily productivity, So
everybody just wants to not be so tired, not be so stressed, not be so sick. Not be constantly thinking about the aches and pains. They don't want to think about their knees every time they get up to pee. They just want to pee. Just smile more. Well, this has been fantastic. You've taken us down a path that I didn't even know was a thing, and until I started diving into it. So this has been really interesting. So wow, thank you so much.
It's what I can do, right?
Yeah.
What I can do to make the world a better place.
No, this is wonderful. It's going to take these kind of conversations and hearing these for, people to change their mindset. And you change your mindset and you look at, a problem a different way, a different angle, and all of a sudden it's so much easier to tackle because you know your path forward. So
you know your why. Yeah, you
Yeah.
kind of know. Yeah.
It
And
makes
until
all
you
the,
understand it, yeah. And you say, I mean, but I like chocolate. Well, I do too. I thoroughly love chocolate. I'm not saying I don't, right?
yeah.
Like, I don't live in this la world where I just love Brussels sprouts. I mean, I actually do like them a lot, but it's not that I dislike eating those other things, but I also have a very big why of I really
Yeah.
want to be very productive with my day and feel good.
Yeah.
And
Yeah.
so when I look at it and say I could do that thing that feels really good, but then I lose all the momentum for all those other things I want to do all day.
Yeah. I got it. I got it. Makes sense. So, all right. So why don't we take just these last few minutes to tell us, about your practice or anything exciting you're working on right now, or just anything you want to share.
I mean, I'm working on so many things at once. I mean, to me, one of my bigger things is the healthcare system is not set up to implement a way of making this accessible to everybody. We as clinicians don't get to talk about these things very much because we're in a churn through. So we have to fix the healthcare system as a whole to really support people as they want to do this. And so I think that's my biggest, what do I want to do in this world? Now, how do you do that? I don't know. The whole healthcare system is set up against that. So, it's hard. And so I think, to me, the place we start is self-funded employers that have the ability to create a healthcare ecosystem within their population, especially those that already utilize direct primary care or on-site clinics or near-site clinics where they have a little bit of control over that. Can we get those clinicians to really approach healthcare that way? And can we set up those benefit plans to say, if you want to do this, let's do that. Let's not penalize you for going to your doctor to talk about nutrition or make that come out of your copay. So I think we have to shift the incentives to align with a healthcare ecosystem that helps with this. It's actually very cheap to treat with nutrition compared to medications, but the alignment needs to happen there. So that's kind of what I'm working on. That's kind of a gathering of a lot of fragmented people out there that are working on it in different ways. And I think we're starting to come together.
Yeah,
Which
just
is
start
really,
talking.
really fun.
Yeah, that's neat. And once we get corporate America and, small and medium-sized companies to come on board.
And I think we have to get them to realize they have that power. Like, shifting the government, Medicare, Medicaid, it's not going to happen. Like, they're going to be the last ones to shift. I wish they weren't, but that's just, it's such a behemoth. It's like turning a cruise ship. They aren't nimble enough to turn. But these smaller employers, and they're the ones taking it so hard right now financially with this healthcare system. So I think we have to get to them. So I've been speaking at coalitions more, trying to consult with these small employers, saying, here's ways we can do it. I don't know that we all have it figured out, but it's not a prohibitively expensive process at all.
Well, that's reassuring to hear.
Yeah, exactly. Like, I think it just takes thought.
Yeah.
And it takes, thinking outside the box a little bit. And it takes some being willing to throw yourself out there and say, we're going to try this thing. And, so I'm writing a book about that right now because I don't know if it'll touch anything, but since it's something I've always wanted to do, so I'm doing that.
Oh, that's cool.
I don't have a title for it yet, but when it comes out, like, I just want people that create benefit plans to read that and say, let's talk about it, And I think obesity medicine is the kind of the way in because that's the words people use and it's the thing that people anchor onto. So I think we have an opportunity to say, okay, rather than just spending $20,000 a year on all your employees for an injectable medicine that's not treating the problem, could we find
do something different,
a medium?
Yeah.
So I think the world has shifted, right? I don't know what it's going to look like, but I think the employers have more power than they realize, and I think they're paying for it more than they realize. So just talking.
Yeah, that solves a lot of problems.
I have a clinic, but it's only for people in Kansas. So, if your listeners aren't in Kansas, then it probably doesn't help. But this is what we do all day long in the clinic is we have an insulin-lowering clinic, which is really fun.
Oh, that's cool to hear you say it's fun. It is neat because you get to, change lives. So if somebody listening wanted to shift the direction of their company and were interested in this kind of stuff, how can they find you? How can they get a hold of you?
I mean, probably the easiest way is CourtneyYoungloveMD.com.
Courtney Young, MD.
That'll get you to that. Yeah, I mean, kind of all the little buckets. Yeah, CourtneyYoungloveMD.com. I'm working for Journeys Metabolic, which is working just on value-based care health systems. It's kind of its own little niche out there. Those are big entities. So, small, mid-sized employers really have to get in the other way. That makes sense. Path in. And, I think it's let's have brave conversations and see if we can all align ourselves in one direction. And I think we should keep talking about it. Like, keep having podcasts talking about this stuff. I think getting out of the mindset that we just are all on a pathway to poor health is It's a terrible mindset.
There's all these different components, but it all comes back to the same thing. Fixing our metabolic
health. And it's going to take physicians. And I want to test the physicians. They're hard to get to because they're all just, cowering in the corner being bombarded by so much that
doing everything they can to keep their head above water.
Yeah.
Helping as many people as they can. So,
that's mayors need to help.
Yeah. Dr. Younglove, thank you so much for shedding light on this. And hopefully somebody listening will, you'll be able to touch them and just make things a little bit easier for them. So appreciate it.
Well, thanks for having the podcast and having the conversations. People need to hear them.
Yeah, and we'll put your contact information in the show notes, so if anybody wants to get a hold of you. But again, thanks. Appreciate it.
Have fun. Bye.
Thanks. Thanks so much for listening. Please rate and review the podcast on the platform of your choice so we can reach more people and more people are recommended this podcast. And if you really liked it, the single best way you can help us grow is by telling your friends. Now, for all the legal stuff. The views and opinion expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. For my day job, I'm an employee of AbbVie and appear on this podcast on my own accord and not in the professional capacity as an AbbVie employee. All viewpoints provided are my personal opinions and not intended to reflect those of my employer. If you have any questions or comments, please shoot me an email at jollie@interrupthunger.org. Let's go spread some joy, people.